Good afternoon, everyone. COE PGIMER welcomes all the participants for today's RDLS session. Today's topic is post-exposure prophylaxis for HIV, that is PEP, and the speaker is Dr. Shankar Naidu. Dr. Shankar Naidu, sir, is currently working as the Deputy Program Director with the Center of Excellence at PGIMER, Chandigarh. We welcome you, sir, for today's session and request you to start the session.
Thank you. And good afternoon, everyone. So today we'll be discussing about the very small topic, but very important topic as far as prevention of HIV is concerned. So this will be the objectives of this session. We will be understanding how to identify patients or persons who require PEP, and also what are the regimens of PEP and when should we start them and how long should we continue them. So PEP refers to the comprehensive management instituted to minimize the risk of infection after a potential exposure to a blood-borne pathogen. So this is a general term which can be applied for HIV infection and also for hepatitis B and hepatitis C and other blood-borne pathogens. So today we will be speaking in relation to predominantly regarding the HIV prevention. So PEP is a standard protocol for preventing chances of getting HIV infection when a healthcare provider is exposed to a source patient who is either known to be a HIV positive person or possibly that the person might have been a HIV infected person. So NACO guidelines clearly describes the various risks of infection with various exposures, and also the various preventive measures have been very clearly given in the NACO guidelines. So we'll be dealing in the next few half an hour or 40 minutes, we'll be discussing about these guidelines and what we can do at our ART centers. Then the post-exposure management protocol is an important element of workplace safety. So before we go further, we have to understand that there are two types of exposure. One is the occupational exposure, the other is a non-occupational exposure. So predominantly the PEP as per the NACO guidelines is predominantly is relevant to the occupational exposure. So when do we say that it is an occupational exposure? So any person who is exposed to potentially blood-borne infection during performance of his or her duties. So this can be in the form of a percutaneous injury through needle stick or having a cut with a sharp instrument like scalpel or any other instrument, either during drawing blood or during surgeries or any other procedure. Then contact with the mucous membrane of the eye, mouth or nose with potentially infectious body fluid. Then contact with a non-intact skin, that is where the skin is either chapped or having some issues like dermatitis, or if there is any injury to the skin and over that there is an exposure of exposure to an potentially infectious body fluid. And also if there is a prolonged contact of an intact skin with blood or other potentially infectious body fluids for a very prolonged period of time. So these will be considered as occupational exposure. While in the non-occupational exposure, we can come across exposure at to any of the fluids outside the workplace, like for example having an unsafe sex or any person who has been sexually assaulted. Those will be considered as, and IV drug use, those will be considered as a non-occupational exposure. So who are at risk for this occupational risk? As you can see from this list, any person who is working in a healthcare facility, whether that person is a doctor or a nursing staff or a lab technician, or the person may be a sanitary attendant or any other person who is dealing with a potentially infected material in a healthcare facility, can be at a risk of having an occupational exposure. So this is just to make you all think. I'm sure that most of you would know the answer, but just to make us think, who is at higher risk of getting an HIV infection after an exposure? There are two clinical scenarios. One is a healthcare worker during disposal of sharps from an obscene theater and has a prick on his or her finger after HIV positive delivery. And the second scenario is when the internist had a splash of pleural fluid on his face from an HIV positive individual. So you can answer to yourselves what do you think is the right answer? So in the subsequent slides, we'll be we'll be getting to know the exact answer. So the next question, who is at risk? The answer would be that both of these persons who are exposed to this infectious material are at risk of acquiring HIV infection. So who is at a higher risk? To understand this, we need to uh, know what are the potentially infectious body fluids and what are potentially not infectious body fluids. So blood, any genital secretions like semen or vaginal secretions, CSF, synovial fluids, pleural fluid, peritoneal fluid, pericardial fluid or amniotic fluid, or any other body fluid which is contaminated grossly with blood are considered to be potentially at risk for transmitting the infection. However, we need to remember there are certain body fluids which are not documented to be infectious as such. These include tears, sweat, urine and feces, saliva, sputum and vomitus. But however, if any of these body fluids are contaminated by blood, then these can also be potentially infectious. So the next point we need to see is what is the risk of transmission through various routes. So with blood transfusion, mind you, this is blood transfusion which has not been screened or so that if unscreened blood has been transfused, then the risk of transmission is almost 100%, more than 98%. Then mother to child transmission without any intervention would be 20 to 40%. But we all know that with effective PPTCT interventions, this risk is much less. With the sexual intercourse, the risk is somewhere between 0.1 to 1%, depending on the route of intercourse, with anal intercourse having the maximum risk of 0.065 to 0.5%, whereas vaginal route has up to 0.1%, and oral intercourse will have a maximum of 0.01%. Injecting drug users have a risk of about 0.67%. And as far as the occupational exposure is concerned, needle stick exposure will have 0.3%, whereas mucous membrane splash over the eyes or any other mucosal surfaces, potentially infectious fluid would be 0.09%. So to answer that question of who is at higher risk, the option would be A, because that patient had a needle stick injury, whereas in case scenario B, the person had a mucous membrane splash with infected material. So the other important thing we need to remember is that risk also depends on the uh, type of fluid. There are other factors which will determine the risk of transmission, which we'll be seeing in the subsequent slides. So there is another case scenario. Medical officer presents to emergency care for evaluation of a needle stick injury that occurred 2 days ago while inserting an intravenous line to a HIV positive patient. So the question here is, can you start PEP in this situation? So the answer is obviously yes. So we'll be the subsequent few slides. We'll be seeing why we can start the PEP in this particular person, the time duration when PEP can be initiated. So to better understand this question, we also need to know a few things before starting PEP. One is what is the risk of contracting HIV after an exposure? So are there any factors that might affect this risk? And how effective is PEP? And when to start, and is it too late to start PEP in particular situations like the case scenario that we have seen just now? And what are the drawbacks of starting PEP? And then the last would be what would be the regimens that we can give, and how do we follow up them after we start them on PEP? So this is just a repetition of the previous slide of risk of after an exposure. As you can see, percutaneous injury for HIV is 0.3%, while mucous membrane exposure is 0.09%. Uh, Here we need to remember that the risk of transmission for HIV through percutaneous injury is much lower than the other bloodborne infections like hepatitis B and hepatitis C, with HBV transmission risk being somewhere between 9 to 30%, highest among these three viruses. So there are some factors which will affect the seroconversion after an exposure. As you can see that the odds ratio has been given here. So odds ratio means the odds of having developing seroconversion after this exposure. So with deep injury, the odds ratio is highest at 15. Then visibly bloody device 6.2, device in an artery or vein 4.3, terminally ill seropositive person then 5.6, and if the exposed person is started on PEP, then the odds ratio is much less, that is 0.19. So indicating that use of PEP would decrease the chances of seroconversion. So apart from this, there are other risk factors which will determine the risk of seroconversion. These are, some of them are patient related, like the viral load. Then some of them are related to the various preventive measures that the healthcare professional has used, like usage of gloves. Uh, some studies have shown that there is a 50% to 75% decrease in the volume of blood that is being inoculated after exposure by percutaneous needles, needle stick injury. So 50% decrease can be in the volume can be seen. So the less the volume, the less is the chance that the HIV might get transmitted. Then again, the type of needle also determines the risk. Hollow bore versus solid bore. So solid bore, as we can understand that they will not contain any blood inside the needle. It is only the surface which is exposed, compared to hollow bore needle, where there might be some amount of blood within the within the needles. So hollow bore needle will have more chances of transmitting the infection compared to solid bore needle exposure. And also the timing after which the needle or the other potentially infected surface has been dry also determines the risk of transmission, with a tenfold drop in infectivity with every 9 hours of drying of the surface. So the next step is, how do we manage the patient, the healthcare professional who is coming to us with history of occupational exposure. First is to provide them first aid. Then we have to then we have to establish whether that particular person is eligible for PEP. And if the person is eligible for PEP, we should counsel the person for starting PEP, especially regarding the adverse effects and the utility and the duration for which we have to give PEP. Then the step 4 would be to assess the need for PEP and prescribing PEP. Then step 5 is follow-up and laboratory evaluation. So for the first step, we have to provide the first aid. So it is very important to sensitize all the healthcare professionals regarding the immediate initiation of first aid after a needle stick injury or any other exposure. So if there is a needle stick injury over the skin, then uh, it is a reflex activity that most of us, we put the injured area within our mouth and then suck the blood. So that has to be discouraged, because there would be exposure of this potentially infectious blood material to the mucosal surface of the mouth as well. And immediately we have to wash the wound and the surrounding skin with water and soap and rinse it properly. We have to remember that we should not rub that particular area. Do not apply any antiseptics or bleach, because these agents might cause more trauma to that area, and this will expose a lot of raw area to the potentially infectious fluid. So there will be higher chance of transmission of the virus. Then what should we do if there is an exposure to ice or mucous membranes? For the ice, we need to immediately irrigate the ice with water or normal saline. The position, the head of the person has to be in a tilted position, and another colleague can gently pour water or normal saline over the eye. In persons who are using contact lenses, it is better to leave them in place till the irrigation is done. And once the irrigation of the eye is done properly, then they can remove the contact lens. Because sometimes the contact lens might help in as a protective membrane for further exposure to the other mucous membrane. We should not use soap or other disinfectant within the eye because that will cause irritation to the eye. Then when there is an exposure to mouth, then we have to immediately advise them to immediately spit out the fluid, then rinse the mouth thoroughly with water or saline. And again, we should not use soap or disinfectant in the mouth because they can potentially damage the mucous membrane. And after doing the first aid, then we should advise them to visit the uh, physician or the ART center where they can be assessed for eligibility of PEP. So to determine the eligibility of PEP, we need to remember two things, that is the exposure code and the source code. So exposure code depends on the type of exposure and the body fluid, volume of body fluid and other parameters. So the first question that we need to ask is whether the material that the particular person is exposed to is whether that is blood or contains a bloody fluid or any other potentially infectious material or instrument contaminated with any of these substances. If the answer to this is this particular question is no, then the PEP is not required. But if the answer to this particular question is if the answer to this particular question is no, then the PEP is not required. If the answer is yes, then we have to determine what is the type of exposure that has occurred. So first is whether this exposure is a mucous membrane or which a skin which is non-intact. Then the next question is the volume of exposure. If it is a small volume or few
Excuse
drops
me,
for a
sir. The
shorter
audio is
duration.
not clear.
Pardon?
Audio is not clear.
Okay, okay.
Yeah, it is clear now, sir. Thank you.
So coming back to this, the first question is the mucous membrane or skin integrity is compromised. Then we have to see the volume of exposure. If the volume of exposure is small for a shorter duration, then we can label that patient as an exposure code of 1. If the volume is large or there is a longer duration of exposure, then the exposure code will fall under EC2. If the exposure is on an intact skin, then again PEP is not required. But many a times in our practice, it would be very difficult to say categorically that the person had an intact skin. So we might end up categorizing them under either EC1, EC2, or EC3. So for the percutaneous exposure, then the severity, we have to determine the severity of exposure. If it is less severe or with solid needle, or if it is just a superficial scratch, then it will be EC code 2. If it is a more severe exposure with hollow bore needle or a deep injury, then the exposure code would be 3. So this is again another table showing the category of exposure. Mild exposure is exposure to mucous membrane or non-intact skin with small volumes, or a superficial cut through small bore needles. And moderate exposure is exposure to mucous membrane with large volumes or percutaneous superficial exposure with solid needles. Then severe exposure is any percutaneous exposure with large volume, like high caliber needles contaminated with blood or deep wound during surgeries, transmission of where there is a significant transmission of significant volume of blood, or an accident with material that has previously been used intravenously or intraarterial. So the other thing that determines the eligibility is the source code. So source is this is mainly the patient related code. So if the patient HIV status is negative, PEP is not required. If the patient HIV status is positive, then we have to see whether the patient is asymptomatic and has high CD4 count and the exposure is a low titer exposure. Then HIV source code would be 1. And if there is a high titer exposure, or if there is advanced disease of the patient and with low CD4 count, then the HIV source code would be 2. And if we are not sure about the HIV status, then we have to label that exposure as source code unknown. So most of the time, many a times we come across this particular situation where the residents or the nursing staff come to us and they say if they are not aware of the HIV status of the patient, and the patient might have been discharged now or might have expired, so they are not able to determine the status of the patient. So we have to label that as HIV status unknown. So based on these exposure codes and source code, there are recommendations whether we have to start PEP or not. So this is the exposure code, and this is the description of the code. For easy understanding, I have slightly modified this table. So exposure code 1 and source code 1, then there is no recommendation for initiating PEP. If the exposure code is 1 and the source code is 2, that is the patient HIV status is relatively uncontrolled and there is high viral load and low CD4 count, then PEP has to be given for 28 days. The exposure code is 2 and source code is either 1 or 2, then again PEP is recommended for 28 days. The exposure code is 3 and source code is 1 or 2, then again PEP is recommended for 28 days. If the exposure code is 2 or 3 and the status is unknown, so source code is unknown, then we can give an option to this patient, and the recommendation just says that we should consider giving PEP for 28 days if the HIV prevalence is high in that given population from where that particular person has presented. So if you think that the risk of having HIV infection in that particular patient is very high, then we should consider advising PEP for 28 days in this category. Then the third step is counseling the healthcare professional who has been exposed. So this is very important step, because if the counseling has not been appropriately given, then there are high chances that the person might discontinue after a few days of taking PEP. For various reasons. So it is very important to sensitize these people and also make them understand that why it is essential to take PEP for 28 days, and also what are the benefits and what are the potential adverse effects that the person might experience while taking this PEP. And also we need to make them understand that there is some problem with the window period, because during the window period the test may be negative, and despite that sometimes we might advise them to take PEP. Then we should counsel them for safe sexual practices as long as they are on PEP, and also up till 3 months after stopping through PEP, and they are tested negative for HIV. Then they have to be counseled, especially the women have to be counseled regarding use of PEP during pregnancy and breastfeeding. And many a times the exposed healthcare personnel can be very anxious. So we need to give them psychological support and to relieve their anxiety. Not only immediately after exposure, but while taking the PEP also many a times the person might be very anxious. So we have to give them psychological support. Then in case of exposed persons opts out of PEP even after intensive counseling, they should be advised for testing for HIV, HCV, and hepatitis B at baseline, at 6 weeks, at 12 weeks, and 24 weeks from the date of exposure. That is, 24 weeks will roughly translate to 6 months. So till the next 6 months, we have to advise them to screen regularly. And the other important thing is we have to document this on record. The source and why we are prescribing PEP to this particular healthcare professional, and we have to timely report it to the higher. The evaluation of occupational exposure sources, known sources, then test known sources for hepatitis B, C, and HIV. Direct viral assays for routine screening of source patients are not recommended. Consider using a HIV, rapid HIV antibody test. The source person is not infected with a bloodborne pathogen. Baseline testing or further follow-up of the exposed person is not necessary. For sources whose infection status remains unknown, the source person or the person refuses to get tested for these viruses, then consider medical diagnosis, clinical symptoms, and history of risk behavior, and then determine whether the uh, uh, source can be thought of as potentially infectious or non-infectious. And most important thing is, do not test discarded needles for the bloodborne pathogens. Discarded needles like the needles that have been used to draw blood from these for unknown sources, evaluate the likelihood of exposure to a source at high risk for infection. Consider likelihood of bloodborne pathogen infection among patients in the exposure setting. So the other question is, when should we start PEP? The answer is as early as possible, within few hours. Within 2 hours is ideally desired, but sometimes people do present to us after many hours or after a few days as well. So to answer this question, there is no exact answer when we can say after these many days the PEP is not required. As you can see from this graph, as the exposure time keeps increasing, the benefits of PEP keep decreasing, and there is at certain point the risk of giving PEP would be higher than the benefit of giving PEP. So exactly whether this is at what time point this crossover occurs is not known from various studies. So this is again a picture showing the various stages of HIV transmission. So if we can intervene anywhere before this step, where HIV replicates in the CD4 cells and released into the blood, that is before day 3, there are higher chances that we'll prevent transmission of HIV to that exposed person. So roughly within 72 hours, it is ideally said that within 72 hours we have to start PEP. But after 72 hours, we have to discuss the benefits and risks with the exposed person and then take a shared decision. So various animal models and animal PEP studies have suggested that substantially less effective beyond 24 to 36 hours. And most of the studies in humans, they have given PEP within 4 hours. So we don't know the time after which the PEP might not be very effective. And also analysis of PEP failures from these various trials also do not suggest a clear cutoff time for which PEP benefits of PEP are very less. The second question is, how long should we give PEP? This is a study done in monkeys where PEP was given for either 3 days, 10 days, or 28 days. As you can see from this particular graph, those subjects who have received PEP for 28 days, the seroconversion rate is 0. And anything less than 28 days, the seroconversion rate is significantly high. So even for 10 days, the seroconversion rate is 25%, which is 1 out of every 4, so which is very high rate of transmission. So ideally, 28 days have to be given with PEP. And even the CDC guidelines and other case control studies in humans have also shown that 28 days is optimum to prevent transmission for an exposure. So the key points that we need to remember while prescribing PEP is the PEP should be started preferably within as early as possible, but preferably within 72 hours of exposure. And if healthcare personnel presents after 72 hours of exposure, so PEP can still be used after detailed counseling regarding the benefits and risks associated with it and its effectiveness. And PEP should be made available in the emergency department, labor room, intensive care units, and operation theaters uh, at that particular hospital. And ideally, it has to be available as easily as possible. So storing providing PEP drugs at multiple areas of the hospital is desired. And the exposed person should go to the designated clinic or officer at the earliest for a complete risk assessment, HIV counseling, testing, and PEP. And all hospital staff members must know whom to report for the PEP and where PEP drugs are available. Then, as I again said, PEP has to be started as soon as possible, ideally within 2 hours. Then healthcare professional presents after 72 hours. This is just a repetition of the same thing. Then prophylaxis needs to be continued for 4 weeks and counseling to be done also by the prescribing doctor. And in cases of sexual assault, PEP should be given to the exposed person as a part of the overall package for post-sexual assault care. And another important legal point is any pediatric sexual assault case needs to be notified to the concerned authority as per the POCSO Act 2012. So the other main point of this lecture is the PEP regimens. So for adolescents and adults who are more than 10 years of age and weighing more than 30 kilos, the preferred regimen is TLD, that is tenofovir, lamivudine, and dolutegravir, 1 tablet once a day for 28 days. For any reason, if this combination cannot be given, then the alternative regimens include tenofovir, lamivudine, and lopinavir, ritonavir, or tenofovir, lamivudine, and efavirenz. So these are again to be given for 28 days. In children who are aged more than 6 years and less than 10 years and weighing more than 20 kilos but less than 30 kilos, then zidovudine plus lamivudine and dolutegravir has to be given. And if hemoglobin is less than 9, zidovudine has to be replaced with abacavir. And children less than 6 years and weighing less than 20 kilos, then again zidovudine, lamivudine with lopinavir, ritonavir. If HB is less than 9, zidovudine has to be replaced with abacavir. And the first dose of PEP should be administered immediately, and healthcare providers should be counseled about the safety of the PEP drugs, and the duration of PEP is for 28 days, regardless of the regimen that we are using. So there might be certain situations where we might require an expert opinion. So especially if the source HIV status is unknown, then we have to determine the severity of the exposure and the epidemiological likelihood of HIV transmission in that particular source. Then decision has to be taken whether PEP has to be initiated. So in this kind of situation, an expert opinion is desired. And just for the sake of taking an expert opinion, we should not delay PEP initiation, especially if it is a known or suspected pregnancy. There is a breastfeeding issue in the exposed person, and source patient is on ART or possibly has HIV drug resistance, then we can refer to an expert, but we have to initiate PEP immediately. And refer to an expert in case of drug intolerance or any major toxicity after initiating PEP. Regarding the other blood-borne pathogens like hepatitis B and C, HBV vaccination after an accidental exposure has to be advised to the particular individual. So the HBV vaccination schedule depends on the HBV vaccination status of the exposed person. The person is never vaccinated, then he or she has to be advised for complete hepatitis B vaccination. So the person is vaccinated previously and his or her anti-HBs titers are not known, then we can give hepatitis B vaccine booster. And if the person is vaccinated more than 5 years ago, then again hepatitis B vaccine booster has to be given. If there are adequate anti-HBs antibody titer, that is more than 10 international units per liter, then HBV vaccination is not required. And hepatitis B vaccination, again, this has to be advised and given as soon as possible after the exposure. And we should not wait for the anti-hepatitis B surface antibodies before we advise for vaccine. And regarding hepatitis C, there is no presently there is no prophylaxis or any vaccination available to prevent transmission of hepatitis C after an exposure. So after prescribing PEP, we have to do certain basic laboratory investigations, which includes baseline HIV status, HCV, and hepatitis B status, then complete blood counts and liver function tests. But even if these are not available, we should not delay the initiation of PEP. The PEP first dose has to be given, and subsequently these tests can be done. And this is baseline HIV status is important because if the exposed person is already HIV infected and his status is not known before this exposure, then instead of PEP, we have to initiate that patient on therapy. So the duration would differ. So that is why it is important to determine the baseline HIV status. Then after initiating PEP, then we have to ask the patient to follow up after a week, at 1 week, 2 weeks, and 4 weeks, and at 3 months after initiating PEP to get the other investigations done. We have to monitor for any clinical symptoms suggestive of seroconversion illness within the initial 1 to 1.5 months. Then we should advise them to avoid blood donation during this time, preferably avoid breastfeeding, and avoid to conceive during this period. And person should use universal precautions while up till 3 months after exposure, and refrain from unprotected sexual activities, and adherence and adverse drug reaction counseling has to be done during every week. So what are the investigations that we need to do on follow-up? At weeks 2 and weeks 4, we have to get the CBC, serum creatinine, fasting blood sugar, and random blood sugar, especially if we are using the dolutegravir-based regimens. Then at week 6, we have to test for HIV. Then week 12, at the end of 3 months, we have to test for HIV, and week 24, that is end of 6 months, we have to test for HIV. So PEP drugs are required on an urgent basis after accidental exposure and should be accessible round the clock. In all cases, the first dose of PEP should be offered as soon as possible within 2 hours. The PEP regimen should be made available from ARV drug stocks at multiple places in one particular hospital, so that even if one particular area is not accessible during night, the healthcare professional will not have any delay in acquiring these drugs. The exposed person should go to the designated clinic or officer at the earliest for complete risk assessment and decision whether to continue the PEP or whether any other investigations at baseline have to be done. All hospital staff members must know whom to report for PEP and where PEP drugs are available, and a regular check should be made for expiry of the drugs with replacement of short expiry drugs. PEP cases should be documented in accidental exposure form, and PEP register and reporting of the drug consumption should be done in IMS. So this particular point is very important for all of us who are working in the ART center, because it is our duty to enter them in the PEP registers and maintain a proper record regarding how many people have been advised PEP and the follow-up. So post-exposure prophylaxis is the second best approach to occupational exposure to HIV. So what would be the best approach? So logically thinking, best approach would be to prevent occupational exposure. So for advising like to prevent a occupational exposure, we should know what are the various activities which are associated with increased risk of occupational exposure. So these are data from some of the studies where activities which are associated with needle stick or sharp object injury within hospital. As you can see, during the usage of that particular instrument is the most common activity or most common time when the exposure happens, followed by in between the steps of various procedures, like you are doing a pleural tap or ascitic tap, and multiple steps are involved in this procedure. So in between these steps, there are chances of needle stick injuries. Then significant amount, 10%, is after use and before disposal. So then again, after use and disassembling. So another 10 to 15% is after use and before we discard that particular soiled instrument. So this is again a significant contributor to the needle stick injury related transmission. And also you can see a recapping of the needles, 3% chances that there will be a needle stick injury while recapping the needle. So what are the various devices with percutaneous injury by percentage of total percutaneous injuries reported? Disposable syringes are the commonest, then along with suture needles. Then others are retractors or skin-borne hooks. Then scalpels, which are either disposable or reusable. Various winged steel needle butterflies or other IV sets. Then electrocautery, pre-filled syringes. So these are all potentially devices which are having potential risk of causing percutaneous injury. So for prevention, the next step is taking adequate precautions, that is universal precautions. So primary prevention is avoid occupational exposure to blood and other potentially infectious material, and use of personal protective equipment. And we have to say no to recapping of the needles, as I have already shown in the previous graph. Nearly 3% exposures are because of recapping of the needles. So these are various steps and various things under the universal precautions and use of PEP. Always use protective gear like eye shields and masks, face masks. Then you wear a non-permeable apron while dealing with the fluids. Then consider all. The other important thing is, especially for those who are in the lab, consider all blood samples as potentially infectious unless until proven otherwise. Then follow universal precaution practices, whatever might be the procedure, whether it is a minor procedure or a major procedure. Always follow universal precaution practices. Then safe handling of the sharp instruments by replacing them into their designated area, so that the chance of needle stick injury would be less. And properly disposing of the needles and syringes by using needle destroyers. So key point from this lecture would be that we have to make HIV transmission to healthcare professional as minimum as possible, and we have to stress the importance of implementing universal work precaution in the particular facility. Then consider all patients or samples as potentially infectious unless proven otherwise. PEP initiation within 2 hours has to be ensured, and preferably we have to start within 72 hours and never be delayed due to unavailability of the source status or HIV test result. Documentation and reporting of each such injury or exposure is essential, and sensitization of the healthcare professionals and accessibility of PEP round the clock has to be ensured. And person exposed to the risk of transmission of HIV is also at more risk of getting infected with hepatitis B and C, and they have to be appropriately advised regarding hepatitis B vaccination. These are some of the queries, but I think we can, if there are any other queries from the audience, we can take.
Thank you so much, sir. Any questions from the participants? Please feel free to unmute, or you can put your questions in the chat box. Any questions? Please feel free to unmute your mic. So I don't think there are any questions. Thank you so much for facilitating this detailed session.
Okay, thank you.
Thank you, sir. Thank you to all the participants for patient listening. We'll conclude the session. Thank you, sir.
Okay, thank you so much.